Dementia Researcher with a blog and a rating.
Dementia Researcher blog, McInally, 6325. Dementia Researcher in rural areas, the unique challenges. There's no shortage of published material discussing the challenges of recruiting participants into health research from rural communities. If this already limited pool is further reduced by targeting older adults exclusively, the task becomes even more daunting. Several factors contribute to the difficulty of recruiting in rural areas, including geographical barriers, poor public transport infrastructure, limited healthcare resources, and the absence of major academic centres, which consequently result in fewer studies being conducted. Additionally, the older adults face unique challenges that further complicate recruitment, such as chronic or complex medical conditions, cognitive and psychological changes associated with ageing, polypharmacy, declining mobility, lower literacy rates, and a general mistrust of outsiders. All these elements combined make the recruitment process particularly challenging and not for the faint-hearted. My role in rural research recruitment. As a clinical studies officer for the Scottish Dementia Clinical Research Network, which is now part of the Neuroprogressive and Dementia Network, I had the privilege of coordinating and recruiting participants for several studies within the Scottish borders. This region, with a population of approximately 100,000, is spread across nearly 2,000 square miles, making recruitment a significant logistical challenge. However, contrary to my initial expectations, recruitment targets were not only met but often exceeded. While I would love to attribute this success solely to my own skills, in reality, it was the result of several coinciding factors that created a perfect storm of favourable conditions. Integrating research into routine clinical practice. When the SDCRN was established in 2009, the primary role of CSOs in each health area was to populate an interest register. This involved identifying and assessing patients diagnosed with dementia who expressed an interest in participating in research. As a community psychiatric nurse working within the older adult mental health team, I had direct access to a steady stream of newly diagnosed patients. When I personally had clinical contact with only about 20% of them, I worked closely with all team members. New referrals were discussed collectively, and I served as a constant reminder, some may say a pest, to colleagues to provide patients with research information. This was before the era of remote working, which many would agree has significantly altered team dynamics. As a result, the Scottish Borders achieved a remarkably high level of representation on the interest register, particularly in relation to the region's overall population. By the time the SDCRN began coordinating clinical trials, I was managing 3 nurse-led clinics within local GP practices, meaning that potential participants were already coming to me. After diagnosis and discussion about available treatment options, I would introduce the idea of research participation. I always made it clear that while direct clinical benefits from the research were unlikely, involvement itself could be therapeutic. Many participants found value in the sense of purpose it provided, the opportunity to contribute to future achievements, or simply the ongoing engagements with healthcare professionals. Normalising research as part of routine discussions with patients significantly reduced the reluctance to participate. Explaining research procedures and addressing concerns early on helped alleviate fears. Additionally, the continuity of care, where participants interacted with the same familiar healthcare professional throughout the process, further fostered trust and willingness to engage. This sense of familiarity extended to other healthcare professionals as well. For instance, in 2 studies requiring blood samples, I lacked the necessary phlebotomy skills, which was none. However, Because I had established good working relationship, district nurses were happy to assist. On one occasion when no district nurse was available, a GP willingly stepped in to perform a procedure. I'd suggest this level of cooperation shows how trust and familiarity with a small healthcare rural community can positively impact research recruitment. Overcoming rural challenges. The rural nature of the Scottish borders posed additional challenges, particularly regarding access to specialised medical equipment. If an MRI scan of a certain specification was required, participants had to travel to Edinburgh, involving a round trip of 3 to 4 hours plus waiting time. Despite this logistical hurdle, we found creative solutions, utilising local volunteer driving services, often familiar faces to participants, and personally escorting them when necessary, ensured that travel did not become a barrier to participation. Reflecting on my experience, I can see that some of the perceived barriers to research in rural communities can also serve as an advantage. The small town mentality, where everyone knows each other, again feeds that sense of familiarity and trust. In these communities, healthcare professionals may provide a diagnosis and ongoing support one day, and the next meeting ASDA deciding what to have for dinner that evening. This familiarity and trust helps dispel the treated like a guinea pig or sticking needles in me fears around research. And integrating research discussions into routine clinical interactions, we remove a lot of the scepticism that might otherwise arise. This principle also applies to other healthcare professionals. In my experience, most clinicians are open to participating in research, but are concerned about the time commitment involved. Given the existing demands on their schedule, they are often hesitant to take on additional responsibilities. However, when trust is established and they understand that their role is limited to occasional support, they are generally more willing to contribute. Conclusion. Recruiting participants for health research in rural communities presents unique challenges, particularly when targeting older adults. However, by placing research into normal clinical practice, using the trust and familiarity in these communities, creative solutions can be found, and these barriers can be overcome. My experience in the Scottish borders demonstrates that even in a geographically dispersed population, research recruitment can be highly successful when the planets align. Establishing strong relationships with both patients and healthcare colleagues is key to creating an environment where research participation is seen not as a burden, but as an extension of quality healthcare.
Thank you for listening. Join the Dementia Research bloggers and share your own views.